We can get started. Well, welcome to the DHS Long-Term Care Testing Member Q&A. Thank you so much for joining us today. My name is Catherine Van. I'm the Communications Coordinator for the Oregon Healthcare Association. We're happy to partner with DHS to bring you this event today. Just a couple of things before we get started. All attendees have been muted to eliminate any background noise. But during the webinar, I encourage you to submit questions via the chat feature just on the bottom of your screen. I'll do my best to monitor Linda as well, and she'll ask the questions during the Q&A portion of this event. And with that, I'd like to present Linda Kirschbaum, OHCA Senior Vice President of Quality Services. Hi, Linda.
Hey, Catherine. Thank you so much, and welcome, everyone. We are so pleased to have DHS leadership here today to address the statewide testing plan. We know you have lots of questions, and first of all, I just really want to welcome and extend our thanks to Mike McCormick, DHS's Interim Director of Aging and People with Disabilities. Thanks, Mike. And Jack Honey, the Administrator for Safety Oversight and Quality. So welcome. These two gentlemen are going to provide up-to-the-minute information on the Oregon Long-Term Care Testing Plan. And the updates that have occurred since last Monday. You all have provided a lot of great questions, and we know you're going to have more today. Jack had the opportunity to present at a couple of our member council meetings last week, which generated some great questions. So with that, let's get to the meat of this, and I'm going to turn it over to Mike and Jack. And again, we just really appreciate your partnership on this.
All right, thank you, Linda, and good afternoon, everybody. Thank you for having us here today. Please excuse my messy kitchen in back of me. There have been a lot of developments since last week. The original plan was that today we would be filing emergency rules on assisted living facilities, residential care facilities, both including memory care endorsements and nursing facilities, on how they were going to be required to do 100% testing of all of their staff and residents by September 30th. So we were on track to file rules effective today. And then we, after lots of discussions and feedback that we received, we said, no, we need to hit the pause button and we need to do some more engagement, both with the providers. So we earlier spoke with Leading Age. Now we're speaking with Oregon Healthcare Association. And we're going to be doing detailed implementation work groups that reflect the perspective of both providers as well as residents. And those are going to be happening later in the week. My goal, which could change, but my preliminary goal is that the draft or the emergency rules would be filed a week from tomorrow. I think that's Tuesday the 30th, if I remember correctly. So this was originally going to be a question and answer session on the testing plan and all of the rules that we were going to file. Instead, we want to use this opportunity to really meaningfully engage with everyone, because there was a lot of stuff that we hadn't anticipated. And so this engagement is incredibly valuable to us and ultimately to you, and hopefully it'll produce a better product at the end through our emergency rules as well as an implementation guide. So let's give so some things about this are not negotiable. So I'm going to give you like the overall requirements that we're going to implement through our rules. We know that there's going to be a requirement that all residents of those facilities I mentioned be tested by September 30th. And in case you're wondering, adult foster homes are not included in scope of this. So any residents of nursing facilities, assisted living facilities, and residential care facilities are in scope, as are all staff who work in a building. So even if you're just a billing person and never have any resident contact, if you work in the building of a facility, you're going to be subject to the testing requirements. Now, if you have a corporate office and you don't actually enter the building, then you're not going to be subjected to the requirement. There is a desire, based upon testing availability, to prioritize the order in which testing occurs. And so priority number one are the following counties: Multnomah, Clackamas, Washington, Yamhill, Polk, and Marion counties. And then in order of facilities, it would be nursing facility number 1, any type of facility with a memory care unit number 2, and then after that would be assisted living and residential care without a memory care endorsement. After that priority list would be all remaining counties in the same order I said, with nursing facility, then memory care, then ALF RCF. The responsibility or the burden for facilitating the testing is going to be placed on long-term care facilities. So that doesn't mean that the facilities need to do the testing, but it does mean that there is an expectation that facilities facilitate all of this work. So establishing a relationship with a local lab who can do the testing is the preferred way. And then when and we understand in some areas that's easier, and it's also could be tied to resources. So in some areas, they're not going to be, a facility isn't going to be unable to do that. And in those situations, the local public health authority will be the fallback option. And then when the local public health authority cannot meet the needs of the facility, then the Oregon Health Authority is going to be the fallback option to that, to help facilitate this testing. So for residents, there is an expectation that all of the tests will be billed to their insurance carrier. So lots of Medicare, lots of Medicaid, and a smaller amount of private insurance. And, we're thinking that greater than 95% are going to have these costs covered by the resident's private insurance. Now with staff members, there's also an expectation that the testing be billed to the staff members' insurance carrier. However, for this body of testing, we have a pool of money that we're going to reimburse facilities for unreimbursed staff testing costs. That pot of money is limited. I know that there's, efforts that are going to be ongoing to increase the size of that pot of money. For resident testing, we're going to pay 100% of the unreimbursed testing by insurance for round 1 kind of baseline testing initially. There's also going to be, for new admissions, we're going to adopt a rule that facilities may not admit a new resident to their building unless they come with a negative test. If an individual does test positive, they are generally going to be ineligible for admission until they have received 2 negative test results separated by 48 hours. Now, we understand that there's going to be exceptions to that. Exceptions to that rule are going to be necessary. So we're going to establish a process where facilities can get prior authorization to admit someone with a positive test result. Maybe the facility has the ability to isolate the resident. Maybe they have segregated staff, et cetera. So there will be situations where that'll be permitted, but that would definitely be the exception and not the rule. This also includes any resident returning from an inpatient stay. They need to be tested before they can be admitted into a facility. We were not proposing a testing requirement on residents returning from the emergency room, and I expect that might be a topic of discussion this afternoon. Ongoing testing. There's going to be a requirement. So for 100% testing of all staff with starting 30 days after the baseline testing. So let's say, today is June 22nd. And let's say that I conduct all of my staff testing today, then effective July 22nd, I need to start my monthly testing of all my residents. And initially, and because of the scarcity of testing supplies, there's a desire to have it go out in 25% increments so that, all staff get tested throughout the month, but it's not a demand all at one time. And then in the example I just gave, testing would also need to resume again on August 22nd, September 22nd, October 22nd. I think that that's the basic outline of the requirement. So again, I just want to thank everyone for being here today. And really the purpose of this is to engage with all of you to tell us what you're worried about, things that we need to be concerned about in the implementation and the drafting of the rules and the implementation guide. So I think I'm going to pass it back to Linda to facilitate that conversation, and Jack, Honey, and I will do our best to answer any questions you come up with. You're muted, Linda. I'm not hearing you.
Sorry, had to unmute my phone. Thank you. The universal Zoom wave. So I'm going to read some of these, and I will. What are the expectations for facilities to obtain tests for the repeat testing? Will they be supplying test kits for the ongoing testing if they run out of tests? And then facilities will try a commercial lab.
So the
really,
governor is only committed to paying for the initial round of testing. We received a lot of feedback on the last call about this, about the significant financial burden this would have on, facilities with like 300 employees. It quickly becomes, cost prohibitive. So I think we need to hear that type of feedback. Now, so Linda, I can only take one question at a time. Don't group them in fours.
So I think they were all related, testing kits for ongoing testing. So Mike, is it fair to say that there's still work to be done and details to be hammered out, if you will, on the ongoing testing protocols?
Yeah, absolutely.
as well as funding.
There are tons of details to be worked out. I can tell you that as of this point, the governor's only committed to paying for the initial testing. I expect a lot of advocacy efforts with the legislature and the governor's office to change that decision. But of course, I don't have the authority to change that decision. But lots and lots of details to be worked out.
Sure. And I would just like to say on behalf of your association here at Oregon Healthcare Association, we will be advocating for that ongoing testing. We've had a great deal of feedback from members on the modeling, and as well as our national associations are working on the federal level for that testing. I mean, it's a critical tool we have to have in our toolbox in order to really stay on top of this horrible disease, and it's really the next step. It's our next phase in really wrapping our arms around this, and so we appreciate the work that DHS is doing, and we will be working on both the state and the federal level on behalf of all of you and the residents that we serve. So it's a popular topic. So several questions related to the funding. Let's see. Inclusion of independent living residents and staff. IL is most of our campuses, which means that they are closely tied to our other licensed facilities. So will this be part of the comprehensive plan and operational platforms?
So there is no requirement for independent living residents to be tested amongst this. Now, if a staff member works in independent living as well as one of the licensed settings, then yes, those staff would be required to be tested. And I cannot pass up this opportunity to please encourage all facilities to segregate all of your staff wherever possible. We are seeing some really unfortunate and sad outcomes from facility, a staff member who inadvertently, of course, but infected 3 different licenses because they worked in those 3 different areas and weren't using PPE appropriately. And, best practice, to minimize this risk is to assign staff members to only one building. So my point is that I hope that facilities would minimize or eliminate, ideally, any movement of staff amongst independent living and their licensed settings.
Yeah. Similarly, yes, we can facilitate tests, but providers are financially responsible for testing employees, ? So, and then that is not financially feasible in 5 other states where we work. They've completely covered those costs, many of which are testing weekly. So good feedback. I hope we can take that back to our work groups.
Yes.
So. What happens if tests in round 1 produce positive resident staff test results, extra tests for follow-up testing? Will those be available?
So, my suspicion is that half the, I'm going to let Jack take this one because he hasn't introduced himself and he's incorrectly labeled as Mike McCormick, but I'm going to let him answer that question.
Yeah, that's odd. I am not Mike McCormick. I'm Jack Honey, the Administrator of Safety Oversight and Quality. I think most of you already know who I am. So to answer this question, in the event that we do turn up positive tests in the initial or the ongoing testing, then we would implement what the current protocol is with local public health and the Oregon Health Authority, which typically, if there is a positive, we are looking at requiring 100% testing. So that would already be happening. And then we would work together with the provider to make sure that we've got all of the correct infection control practices in place and are appropriately cohorting, working with those positive residents, and looking at the best options to get through it with the facility. Basically, currently, when we've got facilities with positives, we have been working between DHS and local public health, have been in multiple points of contact throughout the week, providing support, providing guidance, and helping assure that the facilities have what they need.
Good. So we have some feedback on testing only 25% at one time creates significant holes in understanding true issue of existing in our buildings. So thank you for that. And we will compile all of this for the work groups. Is the initial and subsequent monthly testing always for both residents and staff?
So initial is for both residents and staff. Ongoing is staff members only.
Great, thank you. If we have an Abbott rapid test, can that be utilized as opposed to have them tested by an outside lab?
That's a great question, and I assume that the Abbott test is FDA approved, and if it is, and then we need that, because I can tell, I'm glad someone's bringing this up, because the draft rule that we were working on required the test to be administered by a CLIA certified lab. So if the Abbott test is completely kind of like take and use and, you know, independently, then we would need to address that as part of our rules, as long as it's FDA approved.
Okay. Is the, oops, got that one. Gotta scroll down here. If employees work at more than one facility, do they need to be tested at each facility?
I would think so, because each facility, we're not going to get into this, you know, I'm going to, you know, work on the honor system that this, you know, staff in my facility, I know they work in Jack Honey's, and I'm going to trust that Jack Honey will get them tested. I think that you're going to need to get them tested at each building that they work, so that you have that documentation for the potential for compliance audits.
Okay. So related to a new hire, if they don't have insurance coverage, how will the test be initiated and covered?
Well, as of today, the thinking is that the facility would be responsible for the cost of that testing prior to allowing that employee to begin working.
So, Mike, as a follow-up question to that, would that be able to be applied for the staff testing funds, the pool of dollars for uncovered testing?
I don't believe so, but you know, that's another thing where we need that that feedback, because I think it only allows, you're not actually a staff member at that point. So we would need to address testing prior to first day of work or job acceptance, whatever. I see a great question, and I see that I forgot to mention this. So with the rule that we were drafting, which we were intending to file today, was going to permit any facility that did 100% testing from June 1st forward to count towards this requirement. So May 31st, no, but anything June 1st forward will count. So you don't have to wait, you know, if you're so motivated and you want to do it today, but you're worried like, oh, this isn't going to count towards the regulatory requirement, it will. The date is pretty much set in stone that it's going to be June 1st forward. Thank you, Linda.
Great. Yes, and there's just a couple housekeeping items I just do want to address to everyone. That the recording will take a little bit, but we will get it up as soon as possible, and then also we'll compile the questions for everyone as well. So who and how do we notify our first round of testing? As you said, we are responsible for facilitating this.
So we're going to have a regulatory requirement in the rule that we're adopting that will require facilities to report to us. What we haven't resolved is the details of that report, but it's going to need to be reported to your to the licensing entity, Safety Oversight and Quality, who will be tracking all the compliance of this. At an absolute minimum, it's going to have raw numbers, like I tested 70 residents and 140 staff, and here were the results. That's at an absolute minimum. We're kind of having internal discussions about how detailed, what level of detail we want on the report of results, testing results. Okay.
Some of these we have answered, but there's also the question about non-facility staff, i.e. agency, CNAs, EMTs, hospice.
Jack, are you okay taking it from here? Taking this one? And Linda, your camera.
Oh,
dipped.
sorry. I've got 3 screens in front of me. Apologies.
Yeah, at this point, we aren't looking at outside agency staff being tested as a part of this, of the initial and the ongoing testing. I know that there are a lot of questions that have been coming in from providers. For example, if you do have to reach out and use agency staff, and how quickly you usually need them to come in. Do you need some assurance? Do we need some assurance that they've been tested? You know, absolutely, we want to ensure that you are making sure they're using all the appropriate PPE and using all of the correct infection control protocols to make sure that that is a safe situation. But at this time, we don't have those staff included in this testing protocol. But that is, we've been getting a lot of questions about it, as I said, and a lot of feedback. So it is something that we are continuing to flesh out a little bit here internally.
Great. The other question about residents and staff who refuse to get tested.
So residents can refuse. They have that right. And then the rule that we're contemplating adopting is going to be a mandatory testing requirement for all staff.
Where do employees fall in the priority list?
Employees are, you know, frankly, the highest risk. And so, but the priority stays the same in terms of, you know, the highest risk counties and then nursing facility down to assisted living.
Okay. The question is about physician orders for employees. Oops.
So,
and how can they obtain those?
Yeah, and that's a really good question. And I'm not going to attempt an answer on that because I know that there are potential legal implications associated with this topic. I think we just need to flag this as an issue that needs to be addressed in our implementation guide.
So regarding staff who refuse to be tested, or is this required to continue to work? So
that is what we are contemplating in our role, that you must be tested in order to be eligible to work.
So for new admissions, the negative test, what is the time frame of that negative test? For example, 2 weeks ago were they tested? Will that test work for admissions?
No, but that's an excellent question and one that we didn't have a definition of. I would suggest that it should be at a maximum of 48 hours ago. Certainly welcome any feedback anyone has on that topic, but 2 weeks is entirely too long.
Got it. Trying to throw in a couple. Oh, I think there was just a misunderstanding. So it's just the staff or just the residents that have to be retested. Residents only are tested in the initial testing phase, correct?
No, the initial testing phase includes both residents and staff.
Correct. But ongoing testing is just staff.
Just staff, correct.
I think we just had a little misunderstanding. There's a question about delivery of test kits, but that coordination is done by the facility. More payment. So we've got lots of questions, lots of feedback on the funding for staff testing post the initial round of testing. So for the ongoing testing, a number of questions. So I think if people didn't hear the answers to those questions regarding funding for ongoing staff testing, there are advocacy efforts in the works, and that is yet to be determined. The governor's plan, Mike, as you said, is just right now on the initial testing is going to be covered for sure.
Correct.
If a resident is in our IL moving into AL, do they need a negative test result prior to admission?
Yes.
Okay. More about funding refunds for staff with no insurance. Is there a form or a contact person?
So, you know, at this point, there's limited funding for reimbursement of staff testing, and we're adopting an administrative role, which will grant us the authority to make those payments. And we're also going to mandate the use of a department-created request for reimbursement invoice form. And so that will be released out to providers, and it's going to be required for use. So stay tuned on that.
Okay. Let me just kind of scan some more. Question about contract therapy staff who are in the building routinely.
So yeah, again, that's one that will come out with further guidance when we do issue some written guidelines. We are currently looking at what the best practice would be. The consensus seems to be that for those staff in contracted groups that are more permanently in your building, like for example, the way a lot of buildings do their rehab, would want to be considered. So we will try to flesh out some of the individual guidelines for that and send out a bit more.
So question about once having, again, the staff results, if they've done the testing already, but where does that go? And that's, again, yet coming, is that right?
I think that the facility is going to need to collect the results, and they're going to have to report in some form to us.
Okay. There's a question about the type of test. Is there a requirement that all tests be nasopharyngeal swabs versus nasal truvinates or external nasal swabs? And we might as well throw in saliva tests as well, because
So I think we're working under the assumption, and this might be flawed, is that any FDA approved test would suffice.
okay. I think that this question has come up in a couple other sessions, but on mandatory testing for employees, and if they do refuse, are they supposed to isolate at home for 14 days every time they refuse? Obviously, this provides a burden for staffing.
So there are, you know, there are aspects of employment law associated with this question, and I'm not going to attempt to provide an answer, but I fully anticipate that that'll be part of the implementation guide, is to consult with your legal counsel on the policies that you're going to adopt around this.
Surveyors move between multiple facilities. How often will these state surveyors or AAA workers be tested?
Neither are going to be tested. However, it's a reasonable expectation that they use full PPE when they enter your buildings.
The fun one. If resident refuses testing, how do we keep the rest of the residents safe if they are not getting tested?
Jack, can you take that one?
Yeah, if a resident refuses to be tested, then the facility just needs to ensure that you are using appropriate PPE and practicing safe protocols throughout the rest of the facility, that you are still practicing social distancing where you can. And the recommendation is that you just continue to monitor regularly for any signs or symptoms of COVID-19. And then once, if an individual does develop symptoms, you would work with their medical provider to perhaps get them into the hospital or recommend some testing at that time.
So I think there's a number of questions related to staff testing and the mandates if we lose tasks or lose staff, and then what are the considerations, or how are we going to consider making sure that we've got appropriate staffing and workforce resources.
So that's part of the engagement that we're doing here today. I don't know how large of a concern that is. And really, I think that, Jack and I need to, receive that information from all of you.
One of the things, and if there is someone on the call too, we are understanding from a lot of the states that have already done statewide testing, that the percentages are fairly low as to the positive cases. Hard to say because things change week to week, but that does seem to be somewhat of a trend. So if others have different experiences that are working or have done statewide testing, we would be curious on that as well.
I just also comment that already the world is a different place than 2 or 3 weeks ago.
Again, a number of, I think you can see the staffing questions, so most definitely those will need to be addressed. Will in-home caregivers get testing too?
No, that will not be a requirement unless there's somehow, contracted facility staff that come in to work shifts.
This is a little more of a technical one. It states that we are to retest for all occurrences of symptoms. What do we do in the scenario of someone with seasonal allergies that cause a chronic cough?
Yeah, I punt all the hard questions to Jack.
Well, so far, this situation would not change from how it's handled currently, which is that people who exhibit symptoms of that potentially could be COVID-19 really need to have some sort of an assessment or an evaluation by their medical provider. In many cases, they are looking for additional symptoms beyond those commonly occurring allergy symptoms. So, for example, a chronic cough, they would want to do perhaps daily or multiple times a day testing for temperatures. And it really would be case by case and in collaboration with the medical provider to determine when that person would need to be tested.
Great. So again, there's a very common theme of the testing and how the reimbursements will work and that mechanism. I think You've answered that a few different times, Mike, so do you want to do a summary statement on that? I think some people may have joined a little bit later too and maybe didn't hear some of those questions that were answered at the beginning.
All right, so we're working under the assumption that reimbursement for resident testing is going to be very small, if not non-existent. Staff reimbursement testing, we're currently adopting rules and we're going to be publishing an invoice form that facilities need to use in order to submit a request for reimbursement to us. We'll also have that same request for reimbursement for the resident side as well.
Again, more questions about the IL when it's together on a campus. So if we only are testing the licensed, but you have an integrated campus, if we're trying to prevent the spread of the virus, we should be testing IL as well.
And we would highly encourage it, but ILs are unlicensed, unregulated. We have no authority to require it, but it's highly encouraged.
And just echoing that all those residents really live in under the same roof. So, questions? More IL. Again, more testing, fiscal responsibility for the employees. And that really is the ongoing monthly/weekly testing. Sorry, I keep scanning here. More on the IL with RCF. Refusals, very big theme. Couple more people again, if you've tested as of June 1, then that will count towards this initial widespread testing.
It will.
This indicates from previous webinars, it was stated that testing was optional for residents. Today, it's stated that resident testing needs to be 100%. So I think distinguishing between testing 100% of your residents and offering it versus the refusal aspect of that.
Right. So I guess the most accurate way to say is there needs to be an attempt at 100% resident testing, and all resident refusals need to be documented appropriately.
A number of questions about testing that's already been done and what the reimbursement mechanism for that is. So that detail yet to come.
Yes.
So again, and I think this was answered, but just will new hires need to be tested before starting their position?
Absolutely, yes.
Someone's commented the Abbott test has shown a large number of false negatives. How long will ongoing testing go for? Does it depend on the phase of the country is in, number of cases?
I cannot answer that. As of this point, it would be ongoing.
Let's see. So again, We don't know yet the answer on the ongoing testing funding, so. So indication that we can't get orders for employees. So definitely this physician order thing seems to be percolating through these comments. Have there been discussions, Mike, with public health? We've seemed to be able to get orders for staff testing through public health.
I think that the local public health authorities are willing to do some orders like for an emergent situation or an outbreak. I don't think that they're going to be willing to do orders for this exercise unless there was all other avenues had been exhausted. So, Linda, we really need to keep that issue on our radar as well.
Yeah. I'm bouncing to the other. Can you provide a list of labs for providing testing? Yes.
That'll be part of the implementation guide.
Yeah. If we have asymptomatic positive residents, what is our recourse? Can we ask them to utilize the designated COVID-19 facilities? Or do we simply care for these residents with full PPE for 14 days, et cetera?
So yes, you are required to serve those individuals. That's not a basis for involuntary discharge. Now you can work with the resident and try and encourage them to move to one of the EHCCs, but I think that all of us expect that when we do testing of this scale, the number of buildings with positive cases is going to increase significantly. Double, triple, quadruple is definitely a possibility. So I think facilities need to be prepared that they're going to be serving COVID positive residents in the future.
So, newer question, is the department going to provide the facility education to address the requirements for having the communication regarding marginalized communities or populations?
So there, if you read the testing plan, there's like a page and a half on all of the equity considerations that are going to be required for this. And we have staff that are working on the development of those materials. I think it's not reasonable just to kind of like throw it out there and expect facilities to be able to comply with this. So support will be coming on that.
So can you clarify if organizational leaders or regional directors are going into buildings, will they need to be tested in each building or just once per month?
I don't know.
Okay. So we'll have to address the staff that work outside of the building routinely. When will the implementation guide be available?
Well, our hope would be very shortly after the filing of the rules. And so if my target is Tuesday the 30th, then I would hope, ideally within a day or two of the filing of those.
Some of our local public health authorities are indicating they are not wanting a role in the long-term care facility testing, not providing test kits, not providing the testing, whereas there are other local public health authorities that state they're offering to come in and test. What can we expect from local public health agencies?
Sorry, my voice got really dry. I think that I've learned a lot about the local public health authorities since the onset of COVID in March. There are 36 different local public health authorities throughout Oregon, and I tell people, like anything that you measure, there's kind of like a normal distribution curve of the quality of services that you're going to receive from them. Some of them are highly sophisticated and have just been absolutely wonderful through this, and others weren't prepared to address a pandemic of this nature. So I think what I can feel pretty confident saying is that if a local public health authority is unable to assist, that the Oregon Health Authority will step in and provide and fill that gap.
How is our facility to be notified when it's time to start testing? Is there a deadline which to complete the testing once the notice has been given to the facility?
So when we adopt the rule, there will be a general, rule notification like there is with everything else. We'll also issue a provider alert, and then I would expect associations like Leading Age and Oregon Healthcare Association to do member communications to their members on this requirement.
There is a question whether it is doing full COVID testing or the antibody testing.
It's full COVID testing. Antibody testing will not suffice.
What do we do if a doctor refuses to give us an order for testing? How can we get an order for staff?
Well, like I said, the staff testing is the tougher issue with this, and I'm going to reiterate that I highly encourage all the facilities to engage with their legal counsels or else ask for centralized guidance from the Oregon Healthcare Association on this, because we're not going to be able to provide that. There are some sticky issues in here with employment law and what employers can and cannot do. So I caution all of you to exercise extreme caution as you progress down this, but nonetheless, even with all those things I just said, there is going to be a regulatory requirement for mandatory staff testing. And I know that was about as bureaucratic an answer as I could possibly give, and I regret that, but there we go.
Just to chime in too, as with all things, OHCA will be going to work on additional guidances and technical assistance for members once we know sort of the final with the rules and all of these questions. So we are cataloging carefully, and I think honestly we're all trying to land in the same place. We want a system that provides for safety for our staff, for our residents, most importantly, and that is resource supported in all ways, so fiscally as well as not impacting our workforce, or we'll really be in dire straits. So, let's see, I missed the part on staff testing. How often? So do you want to just recap on the staff testing cycle, Mike?
Sure. So you're going to have to initiate monthly staff testing within 30 days of the completion of the initial baseline testing. So the example I gave is, if I completed all of my baseline staff testing today, June 22nd, then I would need to initiate the next round of staff testing by July 22nd, so that it's completed by August 22nd. And then I would, and then it also needs to be completed on September 22nd and October 22nd, November 22nd forward.
All right. The 48 hours apart between negatives, is that CDC guidelines?
I'm not sure if it's CDC guidelines, but I know that that's the practice that's being utilized widely. Don't trust that first test. Wait 48 hours for the second negative test, and then that's a pretty good indication.
Great. I am just scanning some more. We are just about 5 minutes before the top of the hour. Local drive-up test sites will not allow you to get tested without symptoms anymore. This can cause issues to get 100% of employees tested. Funding over 100 employees is a fiscal burden. So I think that comes with, you know, we'll be working on getting a complete list of the testing resources available, the private labs, and as much information so that you've got sort of a one-stop menu to look at. I mean, that's on our task list. We do have some of the commercial labs that are posted on our website. And I know OHA has some of the testing labs on their website as well. Again, baseline testing must occur by September 30. Just trying to speed us along.
And just make sure you're looking. We have about 5 minutes, Linda.
Yep. And I think what we'll do, Mike, is we can collate all of these questions, and then we will sort them into like categories. And if we could do a follow-up Q&A, would that be helpful?
Yeah, I think that we're probably going to need to do another question and answer session after we file the rules and move into implementation. I know I can speak for Jack and say both of us would be absolutely happy to do another one of these upon request. This has been.
No, these are great questions. I think we can. Organize these into topics, and then I think that would help you. I mean, I don't want to not answer someone's question, but there's a lot of them. So, and I want to be mindful of your time, and if you have any wrap-ups at the moment.
No, I just want to say this has been an incredible session. I mean, I'm looking at the number of participants, it's outstanding, and then the engagement is exactly what we needed. There are just so many details, and I'm so glad that we slowed down a little bit, and we're going to hopefully come out with a better product. So thank you to everyone for investing your time here today.
We really appreciate that. We appreciate the partnership, the ongoing work that we're doing together. And, you know, it's amazing what's occurred within the last week, even, and the changes with this program. So I think just want to give our members that confidence that, you know, we want to get to the best outcome that we can on this. And lots of work being done on many of the fronts. So your questions, again, are all very timely, and we'll get kind of a Q&A too that's more direct, and you can see that in the near future. So yeah, I think we could probably be on here for 2 hours if we tried.
Easy.
But we'll go ahead. We'll work with Mike and Jack to get something scheduled for the next one, the next update, and just kind of plan to do that. And then we'll get these questions collated into something a little more digestible for everyone. So with that, we appreciate your time, and always, if you have questions, please feel free to reach out to us here at OHA or OHCA. We are ever available to answer your questions anytime on the job for all of you. So Thanks for your time, and we will conclude our session.
Thank you.
Thanks, guys. Appreciate it.